Welcome to the deep dive. We're here to cut through all that information overload and give you the really crucial insights from your sources, tailor-made just for you, the nursing student. Today, we're diving deep into something absolutely fundamental: nursing assessment, our source. A key chapter from Fundamentals of Nursing, the 11th edition by Potter, Perry, Stockert, and Hall. It's a real cornerstone text. Our mission here is simple: distill what you really need to know to make sharp, informed clinical decisions and ultimately deliver that excellent patient-centered care.
Absolutely. And, this isn't just stuff for exams, assessment. It's the bedrock. Doesn't matter if you're in ICU, community health, wherever. It's foundational for every single registered nurse. It's way more than just ticking off boxes or collecting facts. It's how you start building your clinical judgment, how you see the whole person. Honestly, it's the first, most essential step for real patient-centered care.
Okay, let's unpack that a bit. Clinical judgment, you mentioned it.
Yeah.
That ability to make smart, timely calls for patient care. So let's start broad. The nursing process. We hear it's fundamental, but what makes it so dynamic? Why isn't it just a checklist? Especially when patients, they don't always follow the script, right?
That's a great point.
Huh.
The nursing process, the ANA lays it out in 6 steps: assessment, analysis, and diagnosis, outcome identification, planning, implementation, and evaluation. But the key thing really is that it's not linear, not step 1, then step 2, done. Think of it more like a cycle, a loop. You evaluate the care you gave, and bam, that loops you right back to reassessing. Because the patient's condition's always changing, So your understanding has to change too. It's fluid, responsive.
Fluid, responsive. I like that. It captures how it works in real life. Let's use that case study, Tanya, the nurse, and her patient, Mr. Lawson. He just had surgery, and now he's showing anxiety. Tanya does her initial assessment, sure. But what if he suddenly develops, say, chest pain or gets short of breath? Her assessment has to pivot instantly, right? It can't be a one-time thing.
Exactly. That's precisely why it's so powerful. That cycle lets nurses give truly holistic, patient-centered care. In QSE Inequality and Safety Education for Nurses Institute, they really nail it. Patient-centered care means seeing the patient as a full partner, giving compassionate, coordinated care based on their preferences, their values, their needs. And assessment, that first step, that's where you start that partnership. You connect with them, their family, understand things from their side.
Okay, so it's clear assessment isn't just robotic data collection. It needs serious critical thinking. This is where it gets interesting, I think. How does critical thinking actually elevate assessment? Make it more than just observation?
Critical thinking. It's layered. First off, you need a solid knowledge base. I don't just mean memorizing facts from a book. It's understanding the basics: anatomy, physiology, microbiome. But also the disease process itself, what's normal versus abnormal, nursing theories like growth and development, and critically, communication skills, family dynamics. This tells you what to look for, what to ask.
Gotcha. So back to Mr. Lawson. If he suddenly gets that chest pain, shortness of breath, Tanya's knowledge of pathophysiology kicks in. She knows anxiety and chest pain could mean something serious, like a PE, a pulmonary embolus. So boom, her assessment priority shifts instantly to oxygenation, cardiovascular status. Her knowledge drives that quick action.
Precisely. That's the knowledge base in action.
Yeah.
Then there's experience. And this isn't just, life experience, so that helps. It's clinical experience, seeing patient after patient. Recognizing subtle patterns, those little cues, learning exactly which questions get you the best info in different situations. A newer nurse might, understandably, be more linear, follow the steps carefully, which is fine. But an experienced nurse, they often develop this, intuition sounds a bit mystical, but it's pattern recognition. They see the bigger picture faster because they've seen similar things before.
Right, that intuition built on experience. But for someone just starting out, how do you build that without, 10 years on the floor?
Great question. Comes down to active reflection, thinking back on each patient. What went well? What did I miss? Asking for feedback. Every encounter is a chance to learn. Okay, third element, the environment. Think about it: time pressure. Is it a crazy ER or a quiet home visit? How complex is the task? Are you constantly interrupted? All these things massively impact how well you can assess. It's easy to miss stuff. The trick isn't just knowing this, but having strategies. Like list your tasks, prioritize, guess how long it'll take, manage your time deliberately. And sometimes you just have to learn to say no to things that pull you away if they aren't critical for patient care right then.
Oh yeah, time management is a huge practical hurdle. But it's not just about the clock, is it? It's also the mindset you bring, those attitudes.
Absolutely. Critical thinking isn't passive. It demands certain attitudes. Perseverance, sticking with a problem. Curiosity, asking why. Confidence, trusting your skills, but knowing your limits. Discipline being thorough. Responsibility owning your actions. These aren't just personality traits, you cultivate them. So, Mr. Lawson is still restless despite your first interventions. Curiosity makes Tanya ask more questions
Yeah.
about his fears, maybe his support system. She doesn't just write it off as normal post-op anxiety. She keeps digging, persisting.
The standards kind of guide all this, keep it grounded.
Exactly. You've got intellectual standards like being clear, precise, consistent in your findings, making sure the data is solid. And professional standards, things like the ANA standards of practice, specific clinical guidelines for certain conditions. They give you benchmarks. What should you be assessing here? How do these findings compare to the norm? So boiling it down, assessment really has two core steps, tightly linked. One, gather comprehensive info from all your sources. Two, interpret and validate that data. Make sure it's accurate and you understand the whole picture.
Okay, we've got the how, the critical thinking. Now, the what, where does all this patient data actually come from? What are the main sources nurses tap into?
Well, the number one source, the primary source, is usually the patient themselves, assuming they're conscious, alert, able to talk. But you have to be critical. Sometimes the patient might not be the most reliable historian, maybe due to cognitive issues, severe pain, fear. In those cases, your secondary sources become absolutely essential.
And those secondary sources would be?
Big ones are family caregivers and significant others. Super important for infants, the critically ill, anyone with cognitive impairment. Sometimes, like in an emergency, they might be your only source initially. They can confirm things, give you baseline info, insights into how the patient usually copes. Just always remember, patient permission is key if possible. And be culturally sensitive. How families are involved varies a lot. Like Tanya might talk to Mrs. Lawson to understand Mr. Lawson's usual stress responses. That helps plan his discharge.
Makes sense. What about the rest of the team?
The healthcare team is definitely another key secondary source. Think about handoff reports. The Joint Commission stresses how vital good handoffs are for safety and continuity. When nurses share info during shift changes or transfers, it has to be thorough. If details get dropped, care can be compromised. It's a constant challenge making sure that info transfer is solid.
And the chart itself? The medical record.
Oh, the medical record is gold. It gives you that baseline past history, current objective stuff, subjective stuff, lab results, tests, doctor's notes, consults. It's all there. But of course, you have to remember, I pay. It's all confidential. And lastly, diagnostic data. Blood tests, x-rays, that sort of thing. These results can confirm what you're seeing, like if you see cloudy urine, a culture confirms the infection. Or they might point you to assess something specific, like if a chest x-ray shows congestion, you know you need to listen closely to their lungs. It guides you.
So lots of sources feeding into the picture, and when we look at the type of data we're getting, it basically falls into two main buckets, right?
Exactly. Two main types. First is subjective data. This is everything the patient tells you, their words, how they describe their health problems, their feelings, perceptions, symptoms they report. Mr. Lawson saying his pain is a burning ache, or I just feel overwhelmed. That's subjective. Only the patient can give you this directly. It often reveals really important physiological or psychosocial changes.
Okay, that's what they say. And the other type?
Is objective data. This is what you observe and measure. Stuff you can see, hear, touch, smell. Inspecting that surgical wound, taking a blood pressure, watching how someone walks, noting if they seem restless. That's all objective. And objective data is usually measured against some kind of accepted standard like blood pressure norms or wound measurement scales. The real skill is connecting the subjective what they say with the objective what you see to get that complete understanding.
And as you're gathering all this subjective and objective, there's some really important things to keep in mind, especially with different patient groups.
Oh, definitely. A big one is limited health literacy. This is huge. It means the patient has trouble getting, processing, and understanding basic health info. We often assume people understand medical jargon, but they frequently don't. This can lead to serious errors, like messing up medications. That's why we talk about universal precautions for communication. Basically, assume everyone might struggle. So avoid jargon, break things down into small steps, maybe focus on just 3 key points at a time. Use the teach-back method. Ask them to explain it back to you in their own words. Provide written stuff at like a 5th or 6th grade reading level. Teacher Ed is so important for catching misunderstandings right away.
That proactive approach makes so much sense, preventing problems before they happen.
Exactly. And another key group, assessing older adults. They often need more time. You have to listen patiently, allow pauses while they formulate their thoughts. Also, recognize that normal aging can sometimes mask symptoms or make them appear differently. They might be more subtle or non-specific than in younger folks. And if they have hearing or vision issues, Lean into nonverbal cues. Good eye contact, nodding, smiling, leaning in. Show you're engaged. It builds trust, which is critical.
That's great advice. So maybe a quick reflect now moment for everyone listening. As you collect data in your practice, or even in simulations, are you consciously separating subjective from objective? And when something feels off or incomplete, what's your next step to get more info or validate what you have?
Yeah, building on that reflection, effective communication, building that trust, that's the absolute foundation for a patient-centered relationship. It's what makes patients feel safe enough to share their real story and lets us truly understand their experience.
Which brings us squarely to the patient-centered interview. It's not just firing off questions, is it? It's a conversation based on relationship, focused on learning about their concerns, their needs, and good interview skills. They really pay off. Better problem finding, more accurate diagnoses, happier patients, and they're more likely to stick with the treatment plan. Before you jump into a big interview, though, a little prep helps quick review of the chart, focusing on priorities maybe from the handoff report.
Absolutely. And that interview usually flows through 3 phases. You can think of them using the 4 C's: courtesy, comfort, connection, and confirmation. These guide the interaction.
Okay, so the first C, getting things started.
Right. That's the orientation and setting an agenda phase. You introduce yourself, explain why you're collecting data, reassure them about confidentiality, and crucially, you set an agenda together. What are their goals? Their main concerns right now? Like Tanya with Mr. Lawson, maybe on day 3 post-op. She might say, Mr. Lawson, looks like discharge is coming up in a couple of days. It's important we talk about how you'll manage at home. Are you comfortable now? Can we take a few minutes to discuss those plans? C.
Setting the stage, building trust, focusing on his needs.
That's a really clear, patient-focused way to begin. So once you're oriented, how do you actually gather the details? That's the working phase collecting assessment data. This is the core. Your goal is accurate, relevant, complete info. Big tip. Always start with open-ended questions. Let them tell their story. Tell me more about, or what are your concerns about? A common trap is jumping to conclusions or asking leading questions too soon. You need to actively listen. Use back-channeling those little go on shows they're listening.
Yeah.
Use probing questions, anything else, to get more depth. Then, once you have the narrative, use direct closed-ended questions for specifics. How often does this happen? On a scale of 0-10. This clarifies details and fills gaps.
I can just picture Tanya doing that with Mr. Lawson, asking him open-ended things like, tell me what you think that lifting restriction means for you, letting him explain, then getting specific. What kinds of things do you lift at home? About how much do they weigh? Later, she asks closed-ended questions to check his knowledge. Can you tell me the signs of infection? Did the doctor talk about incision care? She's moving fluidly between open and closed questions.
Perfect example. It's that dance guiding the conversation but letting the patient lead with their story, then clarifying the details. Then finally, you get to the termination phase. You need to wrap it up smoothly. Summarize the key points you discussed. Okay, so we talked about X, Y, and Z. Check with the patient. Does that sound right? Signal the end is near. We have just a few more minutes. And always, always, give them a chance to ask more questions. Make sure they feel heard. Tanya might end with something like, okay, you've given me a great sense of what we need to cover before discharge, and we can definitely include your wife if that's okay with you. It's respectful, confirms next steps.
And it's not just the questions you ask, right? Observation during the interview is huge, too. Watching them as they talk.
Oh, absolutely crucial. You're constantly observing their nonverbals, eye contact, body language, tone of voice, their appearance, how they move. Does what you see match what they say? Inconsistencies are major red flags, or cues as we call them. A cue is just a piece of info, a sign or symptom. Observing cues leads you to make inferences, educated guesses, or interpretations. Like if someone says they're not in pain, but they're grimacing and guarding their side, that observation, that cue, makes you infer they are in pain, and you need to probe more. It's like detective work.
Okay, so we've gathered all this data, subjective, objective, from different sources through interview and observation. How do we pull it all together so it makes sense, especially for documentation and sharing with the team? That's the nursing health history, I assume.
You got it. The health history is that comprehensive record. It's structured, yeah, but should still be adaptable to the patient. It aims for a truly holistic view, not just the physical stuff, but emotional, social, intellectual, spiritual dimensions too. It's about the whole person.
And thinking about the whole person, cultural considerations must be front and center here.
Front and center. It demands cultural competence, knowing your own biases, having some knowledge about different cultural perspectives on health. But maybe even more important is cultural humility. Recognizing you don't know everything, being open, being humble, letting the patient be the expert on their own experience. Always ask about the illness through the patient's eyes. What do they call this problem? What do they think caused it? What worries them most? What kind of treatment do they think will help? Avoid stereotypes. Ask. Don't assume. Value their perspective.
It sounds like a commitment to lifelong learning, really. Never assuming you've got it all figured out.
Exactly right. And related to that is professionalism in history taking, especially with technology now. Electronic health records are essential, no doubt. But some research shows that if the clinician spends too much time staring at the computer screen, the patient feels less engaged. So find that balance. Look at the patient, make eye contact, listen actively. Don't let the screen become a barrier between you. Your presence matters.
Good practical tip. So let's quickly run through the typical sections of that nursing health history, what's usually included.
Sure. You start with biographical information, name, age, basic demographics, factual stuff. Then the chief concern or reason for seeking health care. This should be in the patient's own words, ideally in quotes. Also important, patient expectations. What do they hope to get out of this visit or hospital stay? Relief, information, reassurance. For the present illness or health concerns, we often use that PQRST mnemonic to really dig into symptoms. It's super helpful for getting detailed info. Remember PQRST. P provokes. What makes it better or worse? What brings it on? Q quality. What does it feel like? Sharp, dull, burning, aching. R irradiate. Where is it? Does it spread anywhere? S severity. Usually on a 0-10 scale. How bad is it? T time. When did it start? How often? How long does it last? Does anything else happen with it? Using PQRST really structures your symptom assessment.
That PQRST is such a practical tool. Okay, what else goes into the history?
You need past health history. Previous hospital stays, surgeries, injuries, chronic illnesses, allergies, current meds, prescription, OTC, herbs. Habits like smoking, alcohol use, lifestyle stuff, sleep, exercise, diet, coping patterns. Family history is key for genetic risks, and also understanding their family structure and support system. Like knowing Mrs. Lawson is able and willing to help Mr. Lawson at home is vital discharge info. Psychosocial history looks at their support network, any recent major life changes or losses, how they cope with stress. Spiritual health, their beliefs, practices, sources of hope or strength, anything that might affect care. And finally, the review of systems, ROS. This is a head-to-toe subjective report, asking about symptoms in each body system, any headaches, vision changes, shortness of breath. It helps catch anything missed and often guides the physical exam that follows.
Wow, that's comprehensive. And then, crucially, documenting all of this.
Oh, absolutely critical. Data documentation. It's a legal requirement, a professional responsibility. Your documentation needs to be clear, concise, accurate, timely. It's the record other team members rely on. It forms a basis for diagnosis, planning, interventions, evaluation. If you didn't chart it, legally and practically, it didn't happen. Good documentation is non-negotiable for safe care.
Okay, so we've collected this mountain of data, organized it in the health history. Now what? How do nurses actually interpret it? Turn raw facts into meaningful insights to guide action?
Great question. This is where clinical judgment really shines. You move from collecting individual cues, those signs and symptoms, to forming inferences or interpretations, and then grouping those cues and inferences to identify patterns. Let's go back to Tanya and Mr. Lawson's wound. The cues are suture separation, drainage, redness, tenderness, slight temperature elevation. Tanya looks at all those cues together. Using her knowledge, she infers a potential problem, risk for infection. Seeing that cluster of related cues and interpreting their meaning is a core part of assessment.
And it feels like you're constantly thinking ahead, anticipating what other data might be needed based on the cues you're seeing, like following branching pathways in your head.
Exactly. You're critically anticipating. Okay, I see this. What else do I need to know? Does this finding warrant checking something else? Which leads directly to validation. This step is so important. Before you lock in an inference or diagnosis, you need to validate your data. Compare it with another source. Double-check it. Ensure accuracy. You don't want to jump to conclusions based on one potentially inaccurate piece of data. So Tanya sees the wound changes, cues, infers infection risk, and then validates by checking Mr. Lawson's temperature and maybe looking at his white blood cell count. Validation often leads you to gather even more data to clarify things. It's a safety check.
And for students trying to get a handle on all these connections, there's a tool that can help visualize it, right?
Yes. Concept mapping. It's a fantastic tool, especially when you're learning. It lets you visually lay out a patient's health problems and draw lines showing how they're all connected. It really helps you organize all that assessment data, see the clusters of cues, and how they point towards specific nursing diagnoses. For Mr. Lawson, Tanya's concept map might show links between his pain, his wound, risk for infection, his anxiety about going home, and his need for teaching about self-care. You see the whole picture and how the parts influence each other. It builds that clinical reasoning skill.
This has been such a valuable deep dive. It really highlights how nursing assessment is so much more than just steps in a process. It's this dynamic interplay of critical thinking, knowledge, experience, communication, and really connecting with the patient. That thorough, thoughtful, patient-centered assessment, fueled by sharp observation and great communication, it truly is the foundation for safe, effective, and really compassionate nursing care wherever you end up practicing. We hope these insights really help you on your healthcare journey.
Definitely. And just remember, this clinical judgment, this assessment skill, it grows over time. Every patient, every situation adds to your knowledge, refines your intuition. Keep learning, keep reflecting. That commitment to continuous growth is what will make you a truly insightful, effective nurse who makes a real difference.
Couldn't agree more. Thank you so much for joining us on this deep dive. From everyone here at the Last Minute Lecture team, we're really grateful to have you as part of our learning community.